The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to Navigating Tricky Situations, Confidentiality, and Talking to Parents. My name is Stephanie Swanson, and I will serve as your moderator today. Before we dive into introductions, I'd like to draw your attention to some important logistics. Today's session is being recorded, and you are currently in a listen-only mode. If you are listening on your phone, please enter on your telephone keypad the audio PIN number from the control panel on the right of your screen. We encourage you to raise your hand using the icon on the right of your screen if you'd like to ask a question or offer a scenario. We will then unmute your line so you can speak. You may also send us questions for the speakers at any time throughout the dialog box to the right of your screen. An audio version of this entire session and a PDF of the presentation will be available via email within 48 hours. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-259-8414. So unfortunately today, Dr. Levy has been pulled away at the last minute due to a family emergency and will be unable to present on today's webinar. We wish her well and hope to have her involved in a future technical assistance event. We are joined today by your very friendly coaches, Aaron and Nick, who have more than enough expertise to address any scenarios that you've had and to answer your questions. We'll get started here with Sade, who will give you a little bit of background information on confidentiality considerations.
Good afternoon, everyone. Thanks for having me, and as Stephanie mentioned, I'm just going to quickly go over some high-level things about confidentiality, but before we get into that, we just wanted to do a little bit of level setting with a quick poll question. So we're going to go ahead and launch that now, and that's just, have you ever experienced any confidentiality concerns as a result of your adolescent SBIRT implementation? So we'll go ahead and get that poll launched. Please feel free to just enter your responses on your screen, and we will talk about them shortly. Okay, so as you can see, it looks like about 89% of you have experienced some sort of confidentiality concerns, and that is very much in line with what we were thinking and one of the reasons why we scheduled this session for today, so we can do a little bit of a deeper dive. But really, we just wanted to open with the notion that this is something that a lot of you are struggling with. This is a pain point that we find a lot in adolescent SBIRT implementation, so you are not alone, you are not abnormal, and hopefully today we can provide you with a little more guidance and support on working through some of these challenging situations. So with that, I'll just launch into just a quick overview of confidentiality considerations for adolescent SBIRT. So protecting an appropriate level of confidentiality of healthcare information is an essential determinant of whether adolescents will access care, whether they will answer questions honestly, and whether you'll truly be able to kind of formulate a therapeutic alliance between the patient and the physician. However, with this, there are federal and state laws that need to be taken into consideration. The most important federal law that you need to be aware of as it pertains to confidentiality is the HIPAA Act, the Health Insurance Portability and Accountability Act, and I'm sure all of you are extremely familiar with this. And in terms of minors, there are a couple of exceptions for HIPAA, so I wanted to go over those quickly. So the exceptions to HIPAA are if a minor has consented for the care and the consent of the care is not required, the consent of the parent is not required by state law, when a minor obtains care at the direction of the court, when a parent agrees that a healthcare provider and minor may have a confidential relationship, or when the state privacy laws kind of trump the federal, are more stronger than the federal statutes. So outside of the federal laws, you also need to take into consideration the state minor consent laws in your jurisdiction. These are based on the status of the minor as well as the type of care that is taught. Unfortunately, again, these vary widely by state, so we can't talk too much in the aggregate, but we will be putting together a follow-up resource that helps you to navigate more quickly to the laws that abide by your state or go over your state. So every state has enacted laws that govern whether minors can give their own consent, and these laws are based on the status of the minor. So those are kind of the big things that you need to know about the federal and the state laws. So before I turn it over to Aaron and Nick, I just wanted to go over some key takeaways around these confidentiality laws. I think a lot of this is sometimes gray area, so we wanted to just dig into this a little bit more. So first and foremost, clinicians do not need to disclose use to parents unless the adolescent is in imminent danger. So again, clinical interpretation of this can be gray, but general consensus is that using drugs alone is not immediately life-threatening. Therefore, it does not require immediate disclosure. Another thing that we want to do in terms of confidentiality is make sure that we're explaining the confidentiality policy, including the limits of confidentiality to the patients and parents early and simultaneously. So as we start out this process, we want to make sure that we're being very transparent and clear about the procedures and guidelines around confidentiality. After that, we want, and when we get the patient away from the parent, we also want to reintroduce and reinforce those confidentiality provisions so that we can underscore a foundation of safety and transparency. So again, we talked about some of these decisions being clinical gray area, and if you are unsure if disclosure is appropriate, it is always okay to speak to your supervisor. You can also loop in the rest of your treatment team for additional support or information to inform your decision. Lastly, an awareness of what is required in terms of parental and community partner involvement is really important, especially in instances where RT is imminent. It's good for you as a clinician to have on your mind what exactly will be required in terms of those partnerships so that you can make sure that you're disclosing that information from the beginning so that your client or patient knows exactly what to expect. So ultimately, again, these are some of the most challenging aspects of ESPER implementation, but they only will represent a very small percentage of your interactions. So we want to be mindful that these type of interactions do have the ability to shape your agency's perspective on ESPER. So we want to be very careful about allowing the whole kind of agency understanding of what's going on around ESPER to be based primarily on these difficult or challenging interactions. So it is our hope today that we can answer some of the questions that you've submitted. We can dive a little bit deeper into some of the challenging situations that you've had so that you can help yourself to navigate through some of these things. And with that, I'm going to turn it over to Aaron and Nick. So for this kind of portion of the webinar, we just ask you to submit any questions or concerns or situations that you've experienced regarding confidentiality or parents. And we have Nick and Aaron on the line to help walk us through.
Thanks, Sade. And I just wanted to start off and just pick up a little bit on one of the comments that you just made about how a lot of times I think, you know, some of the situations that Sade started to outline and some of the situations, the vignettes that we're going to go through on this webinar really are the outliers, but they also take up a lot of time, a lot of resources, and they really sometimes become the strongest stories around doing ESPER in the organization. And just like, you know, other kind of high level, high impact situations, we have to be really careful that we don't use those as the color or the guide to how we do SBIRT in our organization, and that also we don't base policies, procedures, workflows, or even organizational culture on those experiences. And so because we have an experience of a parent who refuses to allow their child to go maybe into an exam room or to fill out a screening tool, that we not base our policy or our approach to treating all of our adolescents based on that one situation, as stressful or as time consuming or as resource oriented as it can be. So Sade, I just wanted to flush that point out again, and thanks for bringing it up, because I think it really speaks to sometimes the mistakes that we all make in organizations of making policy or procedure changes based on an outlier type of situation.
Yeah, I agree. I mean, we don't want to, make things that are not sort of the common occurrence into the norm, and have policy around those things. But we do want to, have and create some sort of policy or protocol, really, about what you want to do in these more routine circumstances. And I think that's a lot of what we want to talk about here today, is how to help you kind of move forward and create a policy that covers most of the things that are going to happen, and then we can talk about these kind of cases where you have to work through a little more. So.
Perfect. So we encourage everyone to use the chat box or to raise your hand if you want to submit a question or a scenario. We have a couple of scenarios that sites have already submitted in advance, so I think we can go ahead and get started with one of those. But again, the chat box is open, the question pane is open, so if you have any concerns, questions, please reach out there. All right, so our first scenario, we got this submission in a variety of different ways. That's why you see a couple of sites up there, but they're having initial difficulty getting parents to leave the room. They've started to make a point of letting parents know that their policy is to have them stay in the waiting room during well-child visits, but are there any other options for when parents refuse and demand to stay with their child?
So this is Nick, and I'll kind of start off. Is that I think that according to this vignette, that the first step is great, that you're kind of starting to let parents know about your policy of having them stay in the waiting room. And I think another part of this is also getting comfortable with the policy around the staff. If you think about it, if you are confident and you feel comfortable with the policy, you understand why it is that you're doing it, then your body language, the way you communicate it, the way you talk to staff are going to convey that intention. And so really making this kind of approach of having parents stay in the waiting room really needs to become part of your organizational culture. And in doing that, the staff really need to get comfortable, trained, understand why we're doing it, that you're not doing anything wrong, that you're not splitting the child from the parent, that this is a healthy, important way to provide care to our adolescents. And I think that plays a big role in our approach and how we, quite frankly, sell it. That how we talk to our parents, how we go pick up a child maybe from the waiting room and walk them back to get their vitals. An example is if you think of a medical assistant about to do vitals, very rarely does a medical assistant, unless they're sensing some concerns from the patient and really taking a strong trauma-informed approach to care, but very rarely are they going to ask the patient for specific permission around doing vital signs. That we just kind of go ahead and do those vital signs, hopefully again in a trauma-informed way, but that we're doing those vital signs as a standard of care, the way that we practice, and so it becomes very normal and a normal part of the flow.
Yeah, I would also add to that, even in thinking about the policy, making sure that that's sort of clearly stated really from the beginning. It could be that, as someone comes in with adolescents, you may have some information either up or available that really says that, wellness, well child visits are done, in the exam room without the parent, for any kids above age 12. If you have any sort of age-related criteria, which you may want to have or even consider, just thinking about all the things that are happening. The other thing I would say is, also you want to be very clear about sort of what rights the parents do have. So maybe thinking about the idea that your policy is that kids will have the wellness visit without the parents being present. However, if anything emergent or life threatening or if some immediate need comes up, the parents will immediately be notified and
Right.
pulled into that process. So really thinking about again how you want to ensure confidentiality, but maybe also meet parents sort of need or understanding of, hey, if something, if there's an emergency or something, that, hey, that's something I want to know about, it's something I need to know about. So really thinking about how your policy both helps maintain that confidentiality, but also ensure that parents will have the information they need about something that may be emerging.
Yeah, that's a great point, Aaron. And, I think also helping the staff come up with some language that they can use and how they approach a parent. The other part of this is, well, what if the parent refuses? Well, we recommend that you not get into a discussion of policy right there in the waiting room. That, if a parent says, hey, I want to come back with my child, a lot of times the best way to go is to say, okay, let's all go back to the exam room together to a private place where it is confidential to talk about that. And some language around that. And so saying things in a very casual way, say, if Aaron, if you're the parent, I could say, Aaron, I know you're really concerned about your son. However, the way that we do it here at our health center is that we ask parents just to wait in the waiting room so that we can talk to adolescents. A lot of times they're just more comfortable talking about stuff.
Mm-hmm.
And if there's anything that that is putting your son in danger or that we think is really important for you to know about it, we our policy is that we're going to come out, we're going to talk to you about that.
Mm-hmm.
And I'm saying this to Aaron and to his son at the same time together so that they can both hear the same information. I'm speaking of our policy without real policy speak.
Mm-hmm.
I'm just kind of having a conversation with Aaron. And, our experience is most times parents are pretty okay with that.
Right.
Again, you're going to have the very rare parent who refuses that, and that's okay.
Right.
We're not in here to battle parents or to fight parents. Certainly they have the final call on this stuff.
Right.
It's really about you reinforcing your relationship with that family and keeping them connected to the health center. That's most important.
Right. And I think it's ultimately about ensuring the, best form of care. That's why you have that policy in place, because it's more effective in getting, honest, robust answers from the patient about what may be happening. So I think you really want to, again, have that policy, have that sort of, confidence, maybe even run a few scenarios with your staff about, how to do this. And also, having the policy either stated publicly or on a sign somewhere or some other thing, makes it known that you're not singling anybody's child out, that this is just sort of policy. This is how we do it.
Yep.
How we do business. This is how we do it.
So, Aaron, maybe this is a good spot for us to just pause. And for all of you out there listening at your computers, really, we do want to make this interactive and hear about the real world experiences that you're having or the suggestions maybe of ways that you're talking about doing this at your health center that you found effective. Again, all of us here are the experts, and especially those of you who are doing it right now, implementing this stuff. We'd love for you to jump in. You can do that by way of the chat box. And I don't think we have do we have phone lines open as well, guys? We
Yeah,
do?
so if you just raise your hand, we can go ahead and call on you and we will unmute you so that you can share with the team. We'd love to hear from anyone, especially if anyone from Community Nurse Health or Native Health is on, and they might want to weigh in on their experiences and why they submitted this question or any other, further follow-ups or clarifying issues from anyone else on the line.
Aaron, I do want to acknowledge too that this stuff's not comfortable, right?
Mm-hmm.
A lot of times talking about substance use in general, but even talking about substance use in families, with kids around, with parents. How do we language, the way that I would say, for example, talk to you as an adult is different than maybe I would talk to you as a father, and then different how I talk to you as an adult, a father with your child present. And so it really is code shifting for us. We code shift into these different ways of talking about policy or procedure or confidentiality in a way that our patients or our clients in front of us can understand them, and that is meaningful, and it's a humanistic relationship where I'm not just speaking policy talk. So I do want to acknowledge that this stuff can be really challenging to do, but the more that we do it, the more we make it part of our organizational culture, the more seamless it gets. And there's a parallel process in that when as the staff gets comfortable with this, the patients do too, because it just becomes the way of doing things. And there is an energy there where that parallel process starts to work off each other, where parents pick up. This is just the way we do it here at the health center, like Aaron said.
Exactly.
Perfect. Thank you so much. So it looks like we have a question that came through through the question pane. So we're going to move on to that one. Again, if you have any follow-ups on this first scenario, please feel free to type those in the chat or the question pane. But the next question is, if an adolescent is using heroin, is that an immediate danger since the overdose risk is high and deadly? And that question is coming from Vanessa Payne.
I guess my first thought about it is it could be. It very well could be. Certainly, and you bring up a great point about risk of overdose and those things being very high for that. Certainly, you'd want to know a little bit more information, particularly about what exactly they're using, if they're aware of that. How they're doing it, if they're aware of that. Certainly, I would say personally, if they are injecting heroin, that takes the risk up another notch,
right.
And that would be probably something that we would, see as kind of immediate or emerging sort of process, at least in my view. But again, there's a context to this, and you want to get as much information as you can, while the client is there. So certainly that is something that could be given, where we are with it in terms of levels of potency and other things. But I would want to know a little bit more. But certainly if they were, needle injecting with risks of, infectious disease and other things, a part of that, that would kick it over the top to be something that's emergent for me.
Yeah, Aaron, I totally agree. And getting that additional information is key. An example of when you may not disclose, though, when you may not tell the parent, is if the adolescent comes in and says, yeah, I sniff heroin, once a month. Or I did it 2 months ago. I sniffed heroin at a party. Somebody had it.
Right.
Now, that's a serious concern. It's a perfect opportunity for a BI to talk about your concerns about what's going on here. But I would say that's not a situation, based on the information that we have, that you'd want to necessarily disclose that to the parents, because there's no imminent danger to that child. Certainly that they're using heroin is a danger. We know the long-term dangers of that, but there's not anything that's pressing where that parent needs to know right here, right now, to break that confidentiality. So I hope that helps answer that question.
So just before we move on, I just wanted to check back in with Vanessa, who sent in the question, to make sure that we answered that appropriately for you, or if there are any kind of, did this actually happen, and there's something that you'd like to share with the rest of the folks, just to make sure that we are adequately addressing all of your needs. So how was that, Vanessa?
I definitely think the answer was adequate. It just sounds like it would be a case-by-case basis with how the client is injecting, because definitely they're using the heroin, because definitely if they're injecting, it seems as though that's something immediately, if they're injecting like regularly, like that's something
right.
the parents would immediately need to know, with the overdose risks being so high, with kind of like what you're saying with the potency of the heroin. But definitely if it's kind of something like, oh, I tried this, I did this in the past, maybe not necessarily like immediate they need to know and type of information. So thank you for your help.
And also too, if they're thank you, and so also too, if they're injecting every day, you're probably moving from a BI. You are moving from a BI to an RT, right?
Yep.
And typically, so that's gonna involve parental involvement, and and let's just take for a minute now when we're crossing that bridge from, let's say we do find out that adolescent is injecting daily. A great way to approach that with the adolescent is say, hey, I want to let you know that what we're talking about now, we're starting to move into an area where we're going to need to involve your parents. That, I'm going to have to bring them in here and talk with them about that, and have a conversation with the adolescent before you do it. Let them know what's coming up, why it's going to happen. This way, they're part of the process rather than feeling like this has happened to them.
And
Right.
we were talking about this a little earlier. If there are other sorts of risk factors that are involved in this conversation, if they're using and they're in some other physical imminent danger, or they have some discussion about a particular scenario where either violence to them or some other person is involved, or some other sort of scenario that's a part of that.
Yep.
So at that point, you're probably doing a much more holistic kind of risk assessment if they're saying that. And as Nick pointed out, if they're engaged in some daily use, or they're injecting, you're also moving into a greater severity. So probably thinking about referral to treatment, which is going to then lead you to definitely probably including parents.
Thanks, Vanessa.
Thank you.
Thank you.
Thank you.
So did anybody else have any kind of follow-on issues regarding that scenario? Please raise your hand or put it in the chat box or the question box.
Aaron, as we sit and talk, because you and I, while we work together, we talk about this stuff all the time. But it gets complicated. It can get complicated quick out there for folks, right? So we can come up with all the policy and all the procedure, but like Vanessa said, those cases are really individualized. Now, we can talk in general terms about what we do in this situation or that situation. I think it's really helpful.
Right.
But ultimately, those things come down to your clinical expertise out there and really following what it is that on an individual case-by-case basis with those patients. And also, to not be alone in these decisions. That if you're meeting with an adolescent and all of a sudden you find yourself in a conversation where the adolescent's injecting heroin every day, is scared for his life because he owes a drug dealer, a couple of grand, that's a time to bring your treatment team together. That's a time to involve the other folks that you work with at your health center, let them know what's going on, get guidance, get support. You don't need to be doing that stuff alone. And so I think it's really helpful to bring your team around you to help guide the decision making as you move forward, as you get more information.
And I think another part of that, maybe if it's helpful as sort of a marker in the ground, being a part of this expert project and actually being able to ask these questions allows you to get some critical pieces of information to help make some of these decisions, like frequency of use and severity. So, if someone's using every day to the point that they're passing out, say for alcohol, for instance, or they're, having some other scenario where they're increasingly engaged in other risky behavior, using this process allows for a lot of that to come out. And that'll be some of the key indicators that'll let you know whether or not, hey, we need to, step up sort of the level of treatment and treatment engagement, and potentially bring in, parental, involvement in that process. So doing this is a good thing because it allows you to know when you need to kind of talk to parents or not by looking at severity and the other criteria, frequency and severity. So I think those are the two real kind of big markers.
Great. Thanks so much, Nick and Aaron. So we're going to move on to our next scenario. This one was submitted by Project Vita. It reads, a 14-year-old girl who's brought in for a school sports physical admitted to cannabis use on the screener, but her mom refused to leave the room. The provider suggested that the patient speak briefly to the care manager to learn what services we had available for adolescents. The mom stated it wasn't necessary because the daughter is already getting counseling at school and she needed to leave. So before I turn it over to Nick and Aaron, I know that we have Al from Project Vita on the line, so I just wanted to check in with him or any of his colleagues and see if there's anything else that you wanted to add to the scenario or any, additional clarifying information that you could provide before Nick and Aaron jump into an answer. All right, okay, so let's just Nick and Aaron take it away.
So this is a really cool vignette because the way you read it could really change, how you're experiencing it. It doesn't read mom is really confident that she's getting the services that she needs for her child, or is there a concern that mom is really being an obstruction to the intervention and saying, hey, back off, leave us alone, we don't need help for this. And so, one of the cool things I think that this vignette really speaks to is the power of utilizing motivational interviewing and really going with and flowing and leaning into what we call resistance, and assuming that's what this scenario is speaking about. When the mom says that it's not necessary, that my daughter's already getting counseling at school, using that as the bridge to have the BI anyway, by saying, hey, that's great. I'm so glad that Susie is getting the support that she needs at counseling. We here at the health center are really concerned about cannabis use in our adolescents. This is why we're concerned about it. We're concerned that it's going to impact her physical performance, because we know that it does. And so we're really glad that you guys are so open to talking about this together, that both of you are here in the room and we can all talk about it as a family. And we want you to know that we're here to support you. You take what maybe in this vignette is some lemon and you squeeze it and you make some lemonade. And you really roll with the resistance. You kind of use strengths that you see the family has there, which is that they are all together, and use it as an opportunity to do the BI anyway.
Right. I mean, it's clear that they, if the parents there and they're engaged, clearly they're getting some sort of services already. So that's a discussion point. Like, hey, we want to support you in any way we can. This is part of why we do these sort of screeners and questionnaires, and really just having a conversation about it at that point. That way, it's kind of there, and they're all engaged. Really, having some sort of confrontation with the parent at that point is probably unnecessary, given they're already engaged in some sort of services too. So.
Yep. Aaron, and this vignette reminds me too sometimes of a lot of the situations that I think we find ourselves in when working with parents that really don't think cannabis is a dangerous drug, and that it's okay for their kids to be using it. They may be using it themselves. I just want to remind all of us that the power that we have as providers, and especially as primary care providers, to not underestimate the strength and the meaning that your counseling, that your guidance, and that your words have, even in situations where you may be talking to a parent that poo-poos marijuana use. That your voice as a provider makes an impact. It has a strong, we know this from tobacco cessation, that when primary care providers prescribe nicotine replacement, even though you don't need to prescribe it, and prescribe that their patients stop smoking, those patients have better outcomes because you're harnessing the power and the impact and the meaning that you all have in your patients' lives.
Cool. Thanks so much. So before we hop on to the next scenario, just wanted to check in to see if there were any
Pause for some
other
questions, maybe.
clarifying questions on that. I know Nick brought up marijuana use, and that's something that we commonly get questions or confusions around how to manage and talk to parents about that. So please go ahead and raise your hand, submit something in the chat or the question pane.
I would just, Sade, thanks. I would just love to hear from some of the folks on the line, because you guys are doing it day in and day out. And if all of you have some suggestions about how you're handling these situations, because it's so helpful. It's one thing to learn about it. It's another thing to talk about how to do it. And so I hope today, me talking, I'm kind of doing some half role play. I used Aaron as a parent, because you kind of need to hear how you say this stuff. And I'd love to hear if some of you are willing to share some of those things. I know on some of the teams, some of my coaching calls, you've shared with me a little bit about how you're saying things or the way that you're bringing them up, and it's been really helpful. I've shared those in other coaching calls, and so I'm really encouraging folks on the call, not just those of you who have questions around this or not sure how to do it, but those of you who say, we got this, we do a really good job with this at our health center. Please jump in and let us know and help us support each other in talking about different ways of doing this stuff, because there's also a cultural context that's really important that we take into account. The way that I talk to this mother in New Jersey may be very different the way that I talk to them in Illinois, and so on and so on. And so taking in those cultural contexts of what's going on, not just for the individual patient, but also your community culture, can be really important. Most of you know I was lucky enough to get to work in Hawaii for many years, and there smoking marijuana is very normalized. It's something that it's much different than other communities that I worked in. And so the way that we approached it, the way that we would talk about it, was quite different than, say, the way that I talked about it in Queens, New York.
Yeah, I agree with that. And just to kind of, sort of add on to kind of what Nick has talked about, this is a learning opportunity for not just the patient, but also for their family. It could very well be that they don't know much about this, or they think that it is less severe than it may be. They don't have necessarily all of the resources, the understanding, some of the clinical knowledge about, particularly cannabis use, that they may need in order to make some, good decisions, for themselves and for, their child. So
that's a great point. We forget sometimes they actually don't know the dangers,
right,
or we
right.
assume that they just know, and they really don't sometimes.
Right, and they may not necessarily know, or they may be, in some instances, have some preconceived notion about marijuana, the idea of sort of, maybe smoking a joint in the 1960s, relative to what's happening now. Yeah. There is, lots of distinctions, both in terms of, purity, the amount of THC in the substance, how they're engaged in the use, all the things around it. So this is an open discussion. It may open up some discussions that allow you to provide both parties with, really the information they need to move forward. And I think that's, a key part of this. What you bring to the table is not just sort of that clinical treatment knowledge, but also that actual, clinical knowledge around the substances and around, sort of the pros and cons of use.
Yeah, as Nick mentioned earlier, I know a lot of you are working in with diverse cultural populations and groups. Let's see, let me look at this list. I think Belinda's on from Native Health. Is there anything that you guys have learned at Native Health that has worked particularly well around counseling folks on marijuana use, or just talking about parent removal in general?
We haven't come across many with.
Okay.
I'm not sure how to do this.
Just push the button.
You're doing it.
We can hear you.
You're doing it.
We can hear you.
You're doing it.
Can you hear us?
Yes.
All right, great.
Okay, but were you able to hear us before this?
No, we
No.
just kind of heard some whispering back and forth.
Okay, because we were whispering. We have to come up with a statement for our consent form to introduce this to parents. And we are very excited to take part in this webinar due to the need for this follow-up and to go on, to move forward with this project. But yeah, I submitted just a statement, not really a scenario, earlier today regarding parents' concerns for separating from their children, not wanting to or not knowing whether to say yes or no to separate from their child when their child is called in for a visit. So that was my concern, but it seems like you have already just mentioned it. You already discussed it. So
Okay.
we're just learning more about the other agencies and how they're handling their issues.
Yeah, we haven't had many positive for cannabis yet. We haven't had very many positive, period.
Great.
Yes.
Yeah, that's interesting. Thanks for sharing so much.
You know, and the way that we talk about the to the parent can really not to go back to what we kind of started to talk about, but how we talk to our parents and reassuring them that their child is in good hands.
Mm-hmm.
It can be really important. And so saying things to a resistant parent who's not willing to let their parent go, it's okay to say to them, say, hey, Aaron, I'm going to have Junior right around the corner with me.
Mm-hmm.
If Junior's uncomfortable at any time, I'll come get you.
Mm-hmm.
And if you are uncomfortable and you're really concerned, you can come, let the front desk staff know, they'll call me and I'll come get you.
Mm-hmm.
Why don't you give us a chance? Give Junior and I a couple of minutes, and then I'll come get you, and let's see how it goes.
Mm-hmm.
So you don't make it an absolute thing where I'm taking your child, and that's no. We're just going to go back for a couple of minutes together. Are you willing to try a couple of minutes or a minute?
Mm-hmm.
Maybe you don't even do the screening that visit. You just get them used to separating just a little bit. So working with the parent where they're at, what they're willing to do, assuring them that this is not an absolute thing, that there's options, they can come back, you can bring the child back to them, and really making it something that is not, it doesn't sound so serious, but kind of just a casual conversation about it. It can be really helpful.
Right, and I think you're right. In the sense of being clear that, hey, again, this is sort of the policy, this is kind of how we do things, but also even adding that element of sort of any sort of time, sort of stamp on it. Say, we're going to do the wellness visit, or we have to ask a couple of questions. Our policy here is that, we do that just with the child. So we're going to go into the exam room 3 right around the corner, and it should only take about 5 minutes.
Mm-hmm.
Or it should only take about 10 minutes. We'll bring the child back, but also saying if there's anything that comes up, during that's either, disconcerting or, is an immediate need for us or for them, relative to them, we'll come get you.
Yep.
We'll have the, the assistant call you on intercom to come on back and sit in and talk with us.
Well, we're going to handle it. We're going to handle it the way we handle everything here.
Right.
Together,
Exactly.
Communicate, and talk about it.
Exactly. So making sure you have those parameters, because to be quite honest, if you have parents in the room, parents there bringing their child, they, depending on the age of the child, they're very used to knowing things or knowing sort of what's happening at all times. So this may be a little different for them when you're saying, hey, I need to, take Junior into the room or whomever and talk to them, privately. So giving them some parameters. This usually takes about 5 minutes or 5 to 10 minutes. This is, when we'll come get you earlier than that. Here's the sort of circumstance. And, let's do this. And then if there's any issues, we'll deal with that as it comes up. So having a good policy, but actually having a sort of, confident sort of, tone about it, and just letting them know sort of what the parameters are. And here's where you come in. This is how you can participate.
Perfect. Thanks so much. So let's go ahead and move on to the next scenario. In this scenario, we have a couple of smaller questions, and just like I think we've addressed kind of the first bullet point a bit with is how to deal with parents that want to know everything the child is reporting. But piggybacking off of that, the question is also about how much to document in the EHR and how much to leave out. I know a lot of folks worry about stigma, and they're again going back to those confidentiality laws and what you can share and who can see it. So I'll turn it over to Nick and Aaron for some guidance on that. And also, please raise your hand if you submitted this scenario and you'd like to, add a little bit more background detail or context to inform the answer.
So, the other thing about that first bullet point of how to work with a parent that wants to know everything the child is doing is also, talking to the parent and saying and asking their buy-in, asking their permission to say, hey, I want to talk to Junior in a way where I can assure Junior that what we talk about is confidential. And Aaron, if something comes up that I'm concerned about or that is putting Junior in danger or someone else in danger, I'm going to bring you into the conversation. But would you be willing to kind of give us that okay for us to speak confidentiality? Making, the parent part of the process, and getting them to buy into and giving permission can really be a game changer for parents and have them feel more comfortable. And again, if they say no, say, okay, well, we don't need to do it for this visit, but would you be willing to maybe consider it for next time that you come? And you start to develop that relationship, because a lot of times that's a key piece to getting to where it is that we want to go with that. So Aaron, I don't know if you had anything. I need to use a different name for my my vignettes so we know if I'm talking to Aaron or Aaron the father. But
I think that's exactly I think that's exactly the right sort of approach, is to kind of think about it from that standpoint of even if you want to have the child in a different room, someplace so you can ask these questions confidentially, asking for the parents' buy-in into that process, I think does make a huge difference. You'll probably get consent. Understanding that the parents, you're paying deference to the parent as a parent. Like this is what they do. This is typically how the scenario is. As the child's been growing up, you parents are aware what's happening or not happening, what their child is being taught, what their healthcare status is, those kinds of things. So when you're moving or shifting the paradigm, you want to get their buy-in about that and about this new approach. And I think you also want to reinforce that you're doing this not arbitrarily. You're not doing this just so the child can just sort of vent about whatever. You're doing this because it has an impact on health, and you want to have the most accurate information possible. And we want a place where the child is very comfortable talking about these things. And that may not actually be with the parent there, or maybe some kids don't have as much of an issue with that. But you really want to get that accurate information for the good of the child in terms of healthcare.
Okay, let's just pause for a second because we have Molly on the line who submitted the question, and she might have a little more to add. We unmuted you, Molly.
So I actually didn't submit the question. I think Dr. White submitted it, and we are in different parts of the building, so I don't even know if she's on the call right now. But I think in terms of the dealing with parents, I think you guys have answered that very thoroughly and clearly. I think it's more the EHR that we're concerned about. And in terms of like accessing my chart in our Epic, once a child is 12 years old, the parent has to sign up for certain only access to very minimal things in the record unless the child consents to that. So I know that we have some protection that way, but again, that stigma of having anything related to substance use in a medical record in terms of like military opportunities and just switching from provider, if they move out of town or whatnot. So I think that's kind of where that question comes from and how to sort of leave that out.
So this is an interesting conversation, and I think I have two thoughts about it. And and they're kind of related. So one is just the idea of thinking about the EHR and thinking about diagnoses versus kind of therapeutic notes and those kinds of things. So it sounds like you guys have something set up in the EHR where they get kind of the minimal stuff there, but it also speaks to to be frank, some larger issues that aren't really health center issues, but more sort of, issues related to stigma, discrimination, and other kinds of things. Health centers, general health centers, expert screening, those kinds of things, typically aren't usually covered under 42 CFR, so you don't have that extra protection, there. And there are some larger societal issues. I mean, you're quite right about potential discrimination and other things. But as far as I think you're concerned, your main concern is really sort of the health and well-being of the child in that moment. And clinicians will need that information to kind of make those decisions. So.
I agree, Aaron. And one of the things when I was in my FQHC training new behavioral health providers to document it, a lot of times those therapists, those social workers and psychologists didn't come trained in integrated care. And they were trained in how to document in more traditional behavioral health type settings, which meant writing much more detailed and extensive notes that are not appropriate or needed in working in the primary care environment. So one of the things that I would use as a way to help guide clinicians when documenting is for them to literally imagine everybody on that patient's team around them. So if the patient was standing behind them, the patient's parents, the primary care provider, or anyone that potentially could see the record connected with the patient. So maybe if that record was turned in for disability review for benefits, to write what it is that you need to write and to communicate the important information that you need to communicate in a way where everyone reading that record is going to feel comfortable and okay, first and foremost, the patient, yet still honoring what it is that you need to document as a provider and as a professional person. And if I'm a behavioral health provider documenting use, I need to document those things in the chart. It's the way that we communicate. It's the way that we ensure that everyone uses a integrated treatment plan and chart so that we are all working on the same sheet of music. And so including that information is important, but the detail that we write about it, the way that we write about it, does not need to be, say, done in the traditional sense. And so going to extensive detail about how maybe the adolescent is, I don't know, specifically who they're buying drugs from and how they're sneaking out of fourth period to go down the street to the left in the gas station to meet the guy behind the corner to get the drug. That is a level of detail that's probably not on a typical case necessary to put into the EHR.
Right, and I think you're getting into this idea of sort of, the sort of, basic kind of general kinds of notes that allow, everybody in the situation to be able to move forward with the information they need, versus kind of what we, in sort of the clinical field call sort of therapeutic notes, where you have, more detailed scenarios that allow the therapist to orient themselves to sort of space and time with sort of where they are with the client in therapeutic practice. So that kind of stuff is not stuff that necessarily needs to be, in this kind of detail, in this kind of record. But you certainly want the particulars, client reported using alcohol, score of X on S2BI indicates some sort of alcohol use disorder or potential alcohol use disorder. Client was given a brief intervention, no referral to treatment necessary, those kinds of things. Those are the things that really, are, allow the process to move forward. And the other thing is thinking about, when someone comes in and has a diagnosis of maybe, say, another health condition, diabetes, maybe. What do those notes look like? How detailed are you writing detail about, about the person's detailed sort of eating habits.
It's a great point, right?
Or
Aaron, I don't write a note and say, Nick on Thanksgiving snuck downstairs when everyone went to bed and ate half a pecan pie.
Exactly.
I'm not saying that happened. I'm just saying it's a potential scenario, but I'm not documenting that in my clinical note, right? Because that's right. But I am documenting if my A1C score is 14, and I report that I'm having a hard time managing eating sweets at night. Right.
Yeah, exactly. So just think about it in that context. I mean, this is a condition not unlike anything else you're dealing with in a health center.
Perfect.
And we really do work hard on that here partially to destigmatize it.
Mm-hmm.
And our behavioral health people are very good at only documenting what's necessary.
It's great.
And I think that question really coming from Dr. White as the medical provider, how much do you document? But I know that the reason that we run into this and we are so concerned about it is sort of that, like, yes, it's in the moment. I don't know if it was you, Nick, that said that, but in the moment, what is the patient's need? But then also looking, I mean, really specific, I think, to the military. We have a lot of kids around here who want to go into the military. And we know that some of them might be great in the military, some of them may not. But I think knowing that you could have an impact, I think, is where people struggle on that. But it's right in this moment what's needed.
Right.
You got it, Molly. Yep. And that was Aaron. I can't take credit. That was Aaron. But yeah, you got it, Molly.
Yep.
All right, perfect. So we have time for just one more scenario.
Oh.
I think it came in from Family First, and it's just around mandated reporting for child abuse. So I think Carrie Ann is on the line, so if there's anything else you want to flesh out about that before Nick and Aaron dive in, please go ahead. All right, so go ahead and dive in.
So, I'm not really sure the specifics of what we wanted to talk about around mandatory reporting, but just as a general, we are mandatory reporters. So any time we learn about child abuse or neglect, we're mandatory reporters, meaning that we have to report that to your state's Child Protective Services. One of the things that I always advise around this is if you're not sure, again, bring your team together, talk to your colleagues, and you can always make a call to Child Protective Services as an inquiry call, and to not provide names, but to give general information to say, hey, this is the situation, these are the facts. Can you give me guidance on whether I need to report this or not? Which is always a safe way to go when it comes to if you're finding yourself in the gray area around mandatory reporting issues.
Right, and I think again that sort of whatever your state or locality says about that. Again, health centers are mandatory reporting sites, as Nick talked about. So so that's part of it's pretty straightforward. But the idea of, I think you're not in this by yourself to kind of figure these scenarios out.
Yep.
You can talk to your supervisor, you can talk to your teammates or other people related to the case, make sure that everybody's on the same page about it. And, as Nick said, you can do, an inquiry call to make sure, just to kind of get a sense of, where you are with that.
Yeah, and, I think Molly brought up the dynamics that providers are up against out there, that there are consequences to what we do. The way we document, even, we've all been faced with difficult situations of knowing that we're a mandatory reporter and have to report something. And we know the impact that that's going to have on the family. And we start to judge or think about, wow, is this what's best for this family? But ultimately, that's not an appropriate guidance for clinical decision making. And while it's difficult and it's a place to discuss and disclose in supervision, it's not an aspect of guidance in how we, deal with those situations specifically.
Great. Thank you, everyone, for your time this afternoon. Thank you so much, Nick and Aaron. We hope that this session was really helpful for the folks that are signed on. If you have additional questions or scenarios that you would like the coaches or the staff to address, please feel free to send those to us via email. We can circulate kind of an FAQ document if we have enough additional questions as a follow-up resource. And I will turn it over to Stephanie to close us out for the day.
Absolutely. So huge thank you to Aaron, Nick, and Sharday for all of your insight and expertise today. And thanks for doing it on such short notice. Again, about Sharon, that was a bummer.
And Sharon's coming back, right?
Yeah.
We're going to get
Yes.
Sharon
Yep.
back, which is
Yep.
great.
She'll be involved in future technical assistance.
Great.
But as a reminder, an audio version of the entire session and a PDF of the presentation will be available within the next 48 hours via email. And we ask that you please complete a short survey following the webinar so we can provide an improvement on our technical assistance. Thank you all so much for joining and have a wonderful day.